Hi, welcome to our channel of IGNOU Audiobooks, Indira Gandhi National Open University, School of Continuing Education, SOCE. Diploma in Nutrition and Health Education, DNHE, English. Block 1 Health Indicators. Unit 3 Asian Perspectives on Health and Quality of Life, 3.1 Introduction. Among the Asian countries, China, Thailand, Indonesia, Sri Lanka, Democratic People's Republic of Korea, DPR Korea, Malaysia and Taiwan have made significant advancements in promotion of health and improvement in quality of life of their population. No doubt, Singapore and Hong Kong are equally important in this context, but they are very small countries for comparison purposes. The experiences of some of these countries will be very valuable for promoting health programs in other sister Asian countries like India. However, availability of data is a hindrance and, therefore, comparative perspectives on health from a few Asian countries have been attempted in this unit. They include China, Indonesia, Thailand, Sri Lanka, DPR Korea, Bangladesh and India. Among these, except India and Bangladesh, the other 5 countries have progressed considerably in many aspects of health promotion. As you go through this unit, you will realize that India and Bangladesh are lagging behind in most of the health profiles. Therefore, contrasting comparison of health perspectives in these 7 countries of Asia gives meaningful and representative information on Asia in general. The discussion is focused on available data on various dimensions of health. Among these countries, which include GDP spent on health, medical care as percentage of total household consumption, access to safe drinking water, doctor population ratio, access to health services, access to sanitation, coverage of immunization, care of pregnant women and children by trained personnel, low birth weight, proportion of undernourished population, infant and childhood mortality, maternal mortality, longevity, communication, technology, percentage of adult female literacy rate and contraceptive prevalence. All these aspects together will provide the profile of health and quality of life of populations in developed and less developed Asian countries. Objectives. After studying this unit, you should be able to list the policies and program aspects related to health promotion in selected Asian countries. Compare the health status, epidemiological transition and mortality levels among 7 of the major Asian countries. Discuss the nature of inputs in health promotion programs and assess the level of quality of life in terms of A. Communication, technology, B. Education of women, C. Calorie intake, D. Contraceptive prevalence rate and life expectancy. 3.2 Health policy and perspectives in Asia. The 7 countries of Asia, i.e. China, Indonesia, Thailand, DPR of Korea, Sri Lanka, Bangladesh and India, more or less began their independent existence during the early 1950s. Further, they also promoted their respective national health promotion programs during the same decade. However, these countries follow differential health policies, particularly in terms of investment made in the health sector, which may be a major determining factor in their differential success in this sector of social development. The total expenditure on health as a percentage of gross domestic product, GDP, was 2.34% in Bangladesh, 5.35% in China, 2.87% in Indonesia, 3.54% in India, 3.79% in Thailand and 3.76% in Sri Lanka. In 2018 in China, most of the health facilities are provided free by the government of China. In spite of free medical care, the Chinese people spent 1% of their family income for medical care. Thus, in the national health policies of these Asian countries, differential investment and emphasis have been given by the government as well as the people. As you may see subsequently, China made a breakthrough in improving the quality of life of the population through effective health policies. It is because China had given high priority to health promotion programs in their overall development programs as compared to other Asian countries. 3.3 Health infrastructure and inputs. As you know, health infrastructure consists of several parameters which have direct and indirect influence on health status of the people. These factors include aspects like health personnel, viz., Doctor population ratio, nurse population ratio, peripheral worker population ratio, bed population ratio. Distance to hospital, transport facilities, availability of specialists, super specialities, hospital facility and so on. Out of these factors, you may see certain high priority factors discussed below. Health delivery personnel. A. Doctors, physicians, in most of the Asian countries more or less similar. Hierarchy of staff, types of hospitals and human resource development programs are observed. However, facilities for human resource development in the field of healthcare are more available in China and India but very inadequate in the rest of the Asian countries. Therefore, these small Asian countries depute their candidates to India, England and other developed countries for training in the field of medicine. Of course, they have facility for training peripheral workers in the field of health. Despite these deficiencies noticed in human resource development in most of the small Asian countries, they do not lag behind the big countries like India and China in the health delivery system. Table 3.1 Doctors, physicians and nurses and midwives per 1000 population. Look at the screen. As you can see from the table above, Korea, DPR, has the best advantage of having 3.7 doctors per 1000 population, followed by China, 1.4. India have 0.9 doctors per 1000 as against 0.6 in Bangladesh. In other words, number of doctors in Indonesia and Bangladesh are not even half of the number in Korea, DPR. It is most critical infrastructural facility for better health delivery system in any country. Therefore, inadequate number of doctors to serve the rural population is the key factor for the general poor health delivery system in most of the Asian countries. Although India is fortunate in this context, there is distortion in the distribution of doctors in our country, because more than 2/3 of the doctors concentrate in urban areas to serve only 1/5 of the total population. B. Nurses and midwives. As regards the availability of nurse population in Asian countries, Korea, DPR, tops all other Asian countries, having 4.4 nurse per 1000 population. Surprisingly, India has a moderate nurse population ratio, 2.4 per 1000. Interestingly, Sri Lanka also has a favorable nurse population of 2.3 per 1000 but not a doctor population. The service rendered in the field of health delivery systems is far from satisfactory. Should we not identify the factors for this problem and provide a remedy on a war footing? C. Peripheral workers. Outreach of the program at the peripheral level depends very much on the number and nature of peripheral functionaries employed in a country. Such services are well organized in China and brought through the barefoot doctors, and so also in South Korea, but not in other Asian countries. Although India has a large number of indigenous Days and so also Dukans in Indonesia, they have not been trained and effectively used in these countries. In addition, there is no systematic involvement of these people in health programs. In addition, India produces the largest number of qualified nurses in Asia, and so also doctors, but a very large number of them leave India to serve in other countries. Such a peculiar situation is not there in most of the Asian countries. Therefore, should we not have a rethinking on human resource development in the field of health, manpower planning and successful utilization of trained manpower in a need-based, equitable manner in rural and urban areas, as has been done successfully in China? Utilization of the existing health facilities by the people concerned is another problem noticed in Asian countries. It varies from country to country. However, in most of the Asian countries, except China, 50% or more of the health facilities are not being used by the people. It amounts to colossal waste of investment and various inputs in the field of health. For instance, when 3/4 of the health facilities in China have been used by the people, hardly 1/3 of the facility is being used in India. No doubt, it tremendously varies in India. It is being used by over 80% of the population in Kerala, whereas in Uttar Pradesh the same facility is not being made use of by even 1/5 of the population. In addition, excess health facilities exist in urban areas and very inadequate facilities exist in rural areas. Should we not do something in this regard? Distortion in health inputs exists in certain Asian countries, particularly in India. While China gives highest priority to the rural peripheral health delivery system, in India maximum input is provided to urban hospitals and creation of super speciality hospitals. In fact, most of the patients may not need super speciality facilities. Therefore, how far is it justifiable in investing more money for a minority of population living in urban neglecting the majority of the population living in rural areas? In the two biggest countries of Asia, namely China and India, health delivery is well taken care of in some part the countries but not in others. In addition, certain regions where ethnic minorities, in China, and tribals, e.g. in India, live are not served properly by healthcare programs. Such distortions are seen in other Asian countries as well. Inputs of the health programs also include immunization, oral rehydration, therapy, ORT, access to health services and communication technology. All these inputs substantially vary across these Asian countries. The following table will give you an overview of the inputs provided through the health delivery system in Asian countries. Table 3.2 Different service inputs: immunization, ORT use rate and access to health services. Look at the screen. A comparison of various inputs of health promotion programs in the 7 Asian countries gives a general picture of the preventive and curative service and service facilities in these respective countries. Regarding preventive care, e.g. to immunization programs, the program related to prevention of TB by administering BCG has become almost universal in most of these countries. Similarly, DPT, polio and measles vaccinations have spread extensively in most of the countries. India is yet to strengthen her preventive care services. In all these preventive measures, India is behind most of the progressive Asian countries. Moreover, provision of tetanus toxoid to pregnant women to prevent risk to the life of mother and child and promotion of ORT to avoid dehydration. Deaths of children resulting out of diarrhea are yet to become universal in many countries. In fact, their coverage range is between 25 to 75% only in several countries. Further, overall accessibility to healthcare service in general also falls short of the real requirements in Indonesia and India. On the contrary, China, Sri Lanka, DPR, Korea and Thailand succeeded extensively in promoting these programs. Thus, most of the Asia countries have achieved greater success in healthcare. However, India and Indonesia and such other countries in Asia have to go a long way to achieve complete coverage in health promotion programs, particularly prevention of communicable diseases. 3.4 Sanitation A1 and D Water supply. Sanitation and water supply are two sides of the same coin that affect the health status in rural and urban areas. Their status and availability deteriorate as a result of population pressure, density. In addition, they also reflect the level of development of a country. In fact, level of sanitation and availability of water supply are very unsatisfactory in most of the developing countries, but not in the developed countries. Of course, rapid urbanization and industrialization adversely affected the sanitation in most of the mega cities, even in the developed countries. As a result of education and modernization, sanitation improved in the developed countries, but it remained very low in developing countries because of the low social development of their population. Similarly, water supply, safe drinking water, is becoming a scarce commodity as a result of rapid growth in population and ecological changes. When population grew rapidly and ecology was disturbed by denuding rainforests, safe drinking water became scarce. According to World Bank, more than 785 million people did not have access to at least basic water services and more than 884 million people did not have safe water to drink. 2017, cdc.gov/healthywater. 2 billion people still do not have basic sanitation facilities such as toilets. who.int/news, 2019. This is true in most of the Asian countries. For instance, drying up of the Kaveri River in the southern part of India is a classical example of ecological degradation which affects the sanitation condition in Karnataka and Tamil Nadu states. Table 3.3, percentage of population with access to safe water and sanitation. When you look at Table 3.3 and compare the scenario of availability of safe drinking water, significant differences are noticed among the 7 Asian countries. Countries like Bangladesh and Thailand are on the top with respect to provision of safe drinking water to almost the entire population. The other Asian countries, China, India, Indonesia, Sri Lanka and Korea, DPR, are not so far behind in providing these basic necessities of life to their population. Now, you may be wondering as to how it is important for health promotion. Do you know that diarrhea and dysentery are waterborne diseases in form the major killers of infants in developing countries? In addition, cholera epidemics are also caused through water or food. Similarly, jaundice, typhoid, etc., are also spread through the medium of water and food. Now, you may be aware why safe drinking water is important for health promotion. The level of sanitation reflects the development of a country. It is better in developed countries than in the developing nations. No doubt, it also reflects the cultural diverse of the population because beyond development, sanitation is also conditioned by the culture of the population. For instance, sanitation is of a very high order in Kerala, particularly among the Kurichya tribe in the Malabar region and also among certain sects of Brahmins who are generally educated. A similar situation exists particularly in Korea, DPR, and Sri Lanka. India's performance in sanitation is very poor and is above Thailand and Bangladesh. Sanitation promotes health status of the people. How to develop consciousness on health and sanitation should be our major concern today because sanitation adversely affects the health condition of the population, leading to several endemic diseases. Dreaded diseases like cholera and several other communicable diseases can be controlled only when sanitation is improved. Now, let us see how sanitation exists in Asian countries. Among the Asian countries, Sri Lanka lead with universal better sanitation, which is not there in all other Asian countries except Japan. Next to them, Sri Lanka has progressed considerably in the promotion of better environmental sanitation. India, Thailand and Bangladesh are at the bottom level with very poor sanitation facilities compared to most of the other Asian countries. Now, you may get a realistic picture about sanitation in the context of developing countries of Asia and not to speak of the developed countries in the world. Therefore, improvement of sanitation assumes a very high priority for the promotion of health in India. 3.5 Strategies and education. Strategy followed for health delivery system is different in different Asian countries. In this context, the Chinese experience is unique. 2 important strategies followed in China are worth emulating for the rest of the Asian countries including India. 1. They have a successful barefoot doctor who can reach most of the population throughout China. These barefoot doctors are diploma holders in medicine. In fact, they are selected from all walks of life and given 3 years integrated training in medicine covering the indigenous Chinese system of medicine with the allopathic system of medicine. China has an army of barefoot doctors to cater to the needs of the population. 2. The second novelty of the Chinese health delivery system is called the family bed system. In China, patients will be screened while visiting the hospitals, and most of the patients will be sent back to their families after diagnosis and they are rendered service in their respective homes by the barefoot doctors. Such service minimizes the need for more number of hospitals and in addition psychologically gives confidence to the patients, which is a major prerequisite for curing the disease. These systems of service followed in China deserve replication and emulation in our country too. The strategy of using different systems of medicine is found to vary in different Asian countries. In this context, once again China is in the forefront. For instance, acupuncture is not only popular throughout China but is also being practiced in several developed countries. Similarly, utilization of indigenous herbs and biomedicines, like ginseng, which is found to be effective for longevity, are very popular in China and Korea. In fact, the Chinese diet itself is very appropriate for healthy living because they consume only a cup of rice during lunch and dinner, and the rest are supplemented by fish, meat, and vegetables. In DPR, Korea and Indonesia also peripheral indigenous workers are very popular and useful for health delivery system. They also use the indigenous system of medicine and services. In India we have Ayurveda, homeopathic, and Unani systems of medicine along with the allopathic system. They are not suitably made use of in most states of India except in Kerala and Gujarat. In fact, several medicines of these systems are very effective for health promotion and they are cost effective as well. Therefore, should we neglect them and have prejudice against these indigenous systems of medicine? What should be done to improve their utilization in our country? When we improve the utilization of these systems of medicine throughout India, we may also make a breakthrough in controlling certain diseases and epidemics like in China and DPR Korea. Health education. Health education can be defined as the art of applying social and health sciences to facilitate the development of healthy lifestyles and behavior among people. Information, communication, motivation, and media are essential and integral components of health education. It helps people become health conscious and develop a high value for health. It involves multidisciplinary teamwork in planning educational strategies, in designing multimedia campaigns, in effective use of electronic and mass media, and in folk communication activities. It is the art of working with people of various backgrounds to satisfy their needs by their own actions and resources and by mobilizing the resources of other sectors. Its main function is to create appropriate educational opportunities in varying environments for people to make their own enlightened decisions and act upon them. For this purpose, it uses home, market, and meeting place, community health education, school, student health education, workplace, industrial health education, hospital, patient education, and employees methods and media suitable to the target groups and problems. Ramakrishna, 1992, 18. Health promotion can be achieved largely through health education. It is a cost-effective, trouble-free and appropriate service for the promotion of health. However, it is differentially promoted in several Asian countries with varying success rates. Although health policies of most of the Asian countries provide priority for health education in the policy document, at the implementation stage priority is shifted to curative services neglecting health education. It is largely due to the defective human resources development on the part of the clients. If health education is promoted seriously, morbidity and mortality can be effectively prevented. In fact, health education and its importance is not only increasing in the context of changing patterns of morbidity but also become necessary to prevent the dreadful diseases like AIDS and cancer. Cultural practices may be beneficial or harmful in a society. Health education should identify such beneficial practices for introducing appropriate education for healthy living. In this context, lifestyle is the most important aspect of the culture. In fact, lifestyle forms the major determinant of cancer, AIDS, cardiovascular diseases and diabetes today. It is well known that smoking and chewing of tobacco cause oral cancer. Sexual hygiene has been linked to cervical cancer. Likewise, oral hygiene is related to mouth cancer. And the intake of fibrous food checks colon cancer. All these are culturally determined. Similarly, the type of sexual practices, hygiene involved and the use of condoms determine the occurrence of AIDS. Value attached to chastity is well known in several Asian countries. Of course, its degree varies from community to community. Such a value system is positive cultural trait that prevents AIDS. Another major disease like a cardiovascular problem is again caused largely by lifestyle factors. For instance, excessive intake of fat, status syndrome, associated with obesity, food habits, and sedentary life are aspects of culture which promote cardiovascular diseases. On the other hand, the value attached to vegetarian food, particularly among certain communities in India and Indian origin population in Asian countries, acts as a favorable cultural factor that may help to minimize cardiovascular diseases. Similarly, diabetes and communicable diseases can also be affected by certain cultural practices either adversely or favorably. Therefore, understanding of culture in human behavior forms a prerequisite for the success of health education. Promotion of personal hygiene and environmental sanitation are essential components of health education. Out of the 7 Asian countries discussed here, Bangladesh and India are the most backward countries in personal hygiene and environmental sanitation. The level of hygiene and sanitation are of a higher order in Sri Lanka and Thailand. The situation is also far better in China. The major reasons for such improvement of hygiene and sanitation in other Asian countries are partially conditioned by their cultural practices and promoted through education and modernization. Therefore, high priority must be given for hygiene and sanitation to prevent several communicable diseases in India and Bangladesh, since they have been very much controlled in China, Sri Lanka and Thailand. Important morbidity conditions in this context are the diseases mentioned above and all other communicable diseases, particularly waterborne diseases like diarrhea, dysentery, cholera, typhoid, and jaundice, and airborne diseases like tuberculosis, polio, chickenpox, influenza, whooping cough. 3.6 Quality of life in Asia. Attaining better quality of life is the aim of all facets of development and particularly of health promotion programs. Of course, diverse programs of development give different emphasis to one or the other components of development schemes. Nevertheless, the goals of all programs work through different routes of development to the ultimate goal of improving the quality of life. In this context, certain aspects of social development, which have close linkage between them, have to be examined to explore their interactions and complementary nature to assess the overall quality of life. The indicators that have more relevance to explain quality of life, particularly oriented to the health and allied aspects, have been discussed here. However, not all such factors are covered here because of the non-availability of certain data. Nevertheless, most of the major indicators of quality of life have been included here. They are nutrition, health and well-being, mortality, longevity, social and technological aspects. Quality of life is a relative, multidimensional multidisciplinary concept which aims to achieve all-round improvement in human life. As a result of such progress in quality of life, human beings may improve their life physically, mentally, socially and spiritually. It also leads people to attain better healthy life through safe ecology, relatively tension-free and peaceful environment to pursue sustainable future development. Table 3.4. Table 3.4. Selected dimensions of quality of life in Asian countries. Look at the screen. In a population of a given country, certain group of people are below the national poverty line. They are extremely disadvantaged not only because their quality of life is poor but also because their existence is at stake. The national poverty lines reflects local perceptions of the level of consumption as income needed not to be poor. All the national poverty lines use a food bundle based on prevailing diets that attains predetermined nutritional requirements for good health and normal activity levels, plus an allowance for non-food spending. In simple words, their earnings will be so low that they cannot afford to have a minimum nutritionally adequate diet plus essential non-food requirements. So, the national population below national poverty line is the percentage of country's population living below the national poverty line. According to this concept, let us see how these Asian countries have crossed this bottom level quality of life. About 21% of the India population live below the national poverty line. Bangladesh is second to India, with 15% of population living below national poverty line. However, in Sri Lanka it is 1% of the population which lives below poverty line. Thailand, 0%, tops the Asian countries, followed by Sri Lanka, 1%, China, 1%, and Indonesia, 5%, in raising most of their population above the poverty line. In these 4 countries only negligible population continue to live, see the figure in brackets, below the poverty line. Is it not a lesson for India to rapidly raise her 1/5 population above poverty line and also improve the quality of life of her population? Another indicator manifesting the quality of life is the undernourishment. Undernourishment exists when calorie intake is below the minimum dietary energy requirement, MDER. MDER is the amount of energy needed for light activity and the minimum acceptable weight for attained height. DPR. Korea 47.6%, followed by Bangladesh 13%, are the two countries where calorie intake below MDER is the least among the Asian countries. China 97% has the best nutritional status, followed by Indonesia and Sri Lanka 93% each, then Thailand 92%, Bangladesh 90%, India 85%, Korea OPR has only 58% of total population that is well nourished. In fact, low birth weight of baby will also be a function of calories intake along with other factors. In this aspect, China 5.0%, India 10.5%, Thailand 10.5%, and Indonesia 10% have the least problem of low birth weight babies, which speak about better quality of life of most of their children. Therefore, the disadvantaged countries as far as infants' quality of life is concerned are Bangladesh 27.8% and Sri Lanka 15.9%. As you know, the above three factors very much influence infant, childhood and maternal. The level of these three mortality rates also indicate the quality of population in these countries. As far as the maternal mortality ratio are concerned, Indonesia 282 is on the top with highest level of mortality, followed by Bangladesh 2015 and India 143. However, Thailand 24, followed by China 27 and Sri Lanka 13 have the least maternal mortality ratio. So, Thailand, Sri Lanka and China are better privileged in this respect than India and Bangladesh. What lesson can India learn out of this? How did China, Thailand and Sri Lanka succeeded in drastically reducing their mortality patterns? The answers to this question can be seen in relation to factors such as better sanitation, availability of safe drinking water, favorable ratios of doctor, nurse and paramedical personnel, effective strategies followed in health promotion, priority given to health programs giving emphasis to health education and prevention of diseases. Longevity is a crucial indicator of quality of life, which is once again influenced by the above-mentioned factor. In this respect, Sri Lanka 77, Thailand 77.2, and China 76.7 top the Asian countries in reaching the top level of life expectancy. Once again, India 69.7 is less fortunate in this regard because here life expectancy is the lowest in Asian countries. It is a pity that India, having the third largest scientific manpower in the world, is lagging behind very much in expectation of life at birth compared to several other Asian countries. Two other social and technological indicators of quality of life can be measured on the basis of literacy. Surprisingly, female literacy has become universal in DPR 100% and China 99.8%. Equally fascinating is the successful achievement of female literacy in Sri Lanka 99% and Indonesia 99.7%. Here again, India 90.2% is the most backward nation. It is the female illiteracy which is the key factor for poor quality of life because it has got linkages with most of the factors mentioned earlier. Yet another equally important manifestation of quality of life is the use of effective mass media, viz., TV and personal computers with internet. However, Sri Lanka, China, Thailand and Indonesia have progressed considerably in this field. The situation in Bangladesh is still worse. They have to go a long way in improving this aspect of quality of life, which is necessary for essential development of knowledge and improving the life style. Regarding percentage of households with TV, Thailand tops the Asian countries 97%, followed by Indonesia 72%. But it is inadequate in India 60%. In India and Indonesia, about 7.5 and 9.9 internet users per 100 population have been reported in comparison to Bangladesh, which has only 3.7 internet users per L00 people. For developing countries, computer is a luxury at present. Quality of life of mother and children and also family as a whole is also reflected based on the adoption of small family norm in acceptance of contraception. In this respect, China and Thailand have achieved spectacular success, followed by Indonesia, but Bangladesh and India have to go a long way to achieve success in this program in order to improve the quality of life of women in particular. Epidemiological transition takes place in a country based on the level of overall development. When a country is economically and socially backward, and so also manifests poor quality of life, people in such countries suffer mostly from deficiency diseases, communicable diseases and other diseases caused by poor hygiene, sanitation and soon. All these reflect the stage of pre-transition in epidemiological change. On the other hand, when a country progresses, hygiene, sanitation and nutritional status will improve. Consequently, scientific attitude and behavior takes place. However, pollution of water, soil, air and noise grow with development. As a result, they lead to occurrence of different types of diseases like cardiovascular disease, cancer, diabetes and so on. But communicable diseases in the poor countries will be reduced to the minimum. These changes in disease patterns, based on level of development of a country, contribute to the epidemiological transition. In fact, all these changes affect the quality of life of population, both in developing and developed countries. 3.7 Summary. Now let us think again about what has been discussed so far. This unit covered the policy perspectives on health from 7 major and diverse Asian countries. Subsequent discussion focused on various infrastructure and inputs provided for the promotion of health programs. It is followed by the question of sanitation and water supply. Another major dimension discussed here is on different categories of health personnel, viz., doctors, nurses and paramedical staff, their strategies followed for rendering health care and priority given to health education form the subsequent section. Of course, various inputs provided for prevention of diseases and promotion of health have been highlighted. As a consequence of all these developments, what happens to the quality of life of the population constitutes the last part of this unit. Thank you.